All right, so we're going to bring up the first panel, and this is one, what to expect when perimenopause, menopause, and beyond. And just kind of an overview, talking about some of the questions of women being blindsided, of course, by perimenopause, menopause, and the symptoms, how they all are defined, common symptoms, and how we can find the menopause care that we need. So first I want to bring up a Dr. Oh, gosh. Come on up. Let's not stand on ceremony. Dr. Monica Christmas is the Associate Professor of OBGYN at the University of Chicago Medicine. She directs the Center for Women's Integrated Health and their menopause program. And Dr. Christmas takes a holistic approach to patient care, exploring traditional and non-traditional treatment options. Welcome. Dr. Lisa Larkin is a women's health internist, menopause, sexual medicine, and medical breast expert, physician, and educator, founder and CEO of Ms. Medicine, and currently the president of the National Menopause Society. And more information on these incredible experts and doctors in your folder. All right, let's sit down. I don't know how to be too formal. So we talked a little bit about what we're going to cover in this panel, because I know there's always a lot of confusion. I know you all get these questions anytime someone comes into your office, stops you on the street, asks you on Instagram. But I want to talk a little bit about why this was something I thought was really, really important to discuss. I had no idea that I went into menopause. I landed on the floor of the studio, and I was hot. My heart was racing out of control. I didn't know what was going on. And my journey, I think, is not so unique. I didn't know what was happening. Brain fog was debilitating. That was probably my biggest symptom if I look back over the course of what was going on in my 40s. I'd gone through a divorce thinking, it's just stress. Just stress. I just got a lot of stress, and didn't realize what was really happening to me. So my story is not unique. There's no question about that. But I want to start with you, Dr. Larkin. Why do the vast majority of women entering perimenopause or menopause without information, they enter it with no information, and oftentimes see doctors that cannot really help them?
Right. So this is such an important question, and I like to lump the categories because there's many reasons of why this is. The first really started with the Women's Health Initiative. So that obviously we're going to hear more about. I'm not going to go into details of that. But in 2002, everything changed. And what happened then was, with the initial publication, created fear among patients, but also among doctors. And I can tell you I was already practicing about a dozen years at that point, and I was doing a lot of menopause prior to the WHI. And at that point, doctors stopped prescribing hormones. And what else happened is we stopped teaching doctors about hormones. So since 2002 till now, we have a generation of physicians that really have been inadequately prepared to take care of midlife women. You add to that just fundamental ageism. You've all heard also of the lack of research and investment, which now I'm so excited is really changing. I really see that we're at a pivotal moment in the women's health space. But fundamentally, we've been neglected by research, education, and what that's done is left women who already at midlife fall through the floor, right, in a quandary. The other last thing I'll just say is our healthcare delivery models in the United States don't work when it comes to midlife women's health. So who owns women's health? Nobody owns women's health, right? Women age through their entire lifespan. And so this idea that either OBGYNs or primary care doctors owns women's health is not right? We actually need to work collaboratively. The best model of care for women is OBGYNs and primary care doctors working together, but our system doesn't really support that, right? So then you have the midlife woman who is done childbearing largely in their 40s, isn't seeing their OB very often. They don't have a lot of health issues yet, so they're not seeing me as their internist very much yet. And that 40 to 60-year-old woman has the least points of contact with healthcare providers. And then when they do see their healthcare providers, they're told that menopause is natural and they should just suffer through it, or that hormones are terrible and scary. And so women are really left to fend for themselves. And it's really generated where we are today, right? Which is women not getting the care they need or deserve.
I think that there's so much to dive into, and we'll do that throughout this panel. But Dr. Christmas, I want to have you define perimenopause, menopause, and postmenopause, because I think a lot of us don't know where it starts and ends. Can you talk about that?
Yeah. So perimenopause is well, let me start first. I'll say the median age of menopause, and we define it as not having a period for a full year, is about 52. Some people say 51 and a half, whatever, 51 to 52. The range that 90% of women will fall into is between 45 and 55, right? We start to experience symptoms related to hormonal fluctuations up to 7 to 10 years, depending on what you look at, before you actually go through menopause. So it's quite normal in your late 30s, early 40s, definitely in the mid-50s, to possibly start experiencing troublesome or bothersome symptoms. And there's not one menopause syndrome that everybody is going to get. Some people are really fortunate. They don't have very many symptoms at all. And then there are other people that have every symptom that you could probably get. And there's everything in between. That perimenopause time frame is that 7 to 10 years or so that you possibly are symptomatic. Could be hot flashes and night sweats. It could be noticing that your metabolism is changing and not in the right way, okay? Mood fluctuations, I think, is one of the most common symptoms that I get in that perimenopause time range, because people don't understand where it's coming from. The irritability, and it could be different things. Some people express, I personally had much more sadness than anything. And I'll share that with patients and they'll say, no, that's not how I describe it, right? I'm irritable, I'm angry, and I'm going to tell you about it. And it's frustrating too, because at this stage, many of us are at pivotal points in our career. We have other people that are reporting to us. We're in leadership roles. And if we are, having difficulty managing emotions, that is extremely troublesome. It was for me, because I don't want to be crying every time somebody says something to me, and that's what I was doing, or still am, actually.
You're so right about it. I saw a friend last night, and she goes, I'm weepy. And I said, weepy, that's a good word. That describes it all.
Or people say, I'm not depressed, right? But then they tell me in the next breath that I don't have energy to do the things that I once did. I just am not as involved, but I'm not depressed. But that's anhedonia. That's a form of depression.
Right.
So there's that. And then menstrual changes. I'm a minimally invasive gynecologic surgeon. This is the time when most people are coming to see me, because if some people are fortunate, their periods get shorter, they get lighter, they politely space out. Some people are even better than that. It's like, what's today's date? I forget, May 2nd or 3rd. It just stops and never comes back again. But then there are a lot of people that their cycles get closer together, heavier, longer before they go away. And so, again, all of these things happening in a time frame where, as Dr. Larkin said, people may not be recognizing it. Well, you're still getting your period, so you're not in menopause, it's not that. Or better yet, which they're very not helpful, somebody actually will listen and say, I'm going to check labs for you. And they'll check labs and they'll say, oh, they're perfect. You're not menopausal, and leave. And that's why labs aren't helpful, because those labs, those values, those hormone levels are fluctuating.
Yeah, I do want to go into that. I want to jump real fast, though, into that kind of transition into menopause. So we talk about that long period of time of perimenopause, and then when you know you're in menopause.
So postmenopause is just thereafter, right? When we are children or whatever, you're prepubescent, you're in that phase of life, you start getting your period, you're in the reproductive phase of life, and once those cycles stop, or because your ovaries are no longer producing the hormones that they once did, natural process, you're in the postmenopause phase of life. So I think people think about it, though, in the fact that symptoms start to get better. Sure. So then they think, oh, I'm no longer having hot flashes anymore, so I must be done with the process. You're done with some of those symptoms, and that's a good thing. But that doesn't mean, it just means that you're done with the symptoms, but you're still postmenopause.
Well, yeah, and Dr. Larkin, I'll have you address this part. That is, I hear a lot of people like, I went past that. Every once in a while I hear somebody do that. But you're still postmenopausal.
Right. So I'll back up 1 second just to say, the perimenopause is the time when I see a lot of women really getting blown off by their physicians, right? Because that's harder to define for doctors, right? So your bleeding hasn't stopped. We can define menopause really easily. But what I talk to women about all the time is, we should trust women. Women can tell you when they're perimenopausal. Their symptoms, as Dr. Christmas said, can be very different woman to woman, but women know. I mean, they may not even really be having changes in their cycle yet, but they are a little more fatigued. They are noticing they're having more breast tenderness and mood stuff right before their periods. They may be having intermittent symptoms. Their libido is lower. And I can't tell you the number of times that patients come in to see me and said, my doctor told me that I couldn't be perimenopausal yet because my labs were normal, right? And as you just heard, laboratory testing in the perimenopause is not very helpful. But back to your question, which really is, right, so the reason that this is such an important stage of life, right, and so women can have children by choice, but all women that live long enough will go through menopause. And so yes, it's natural, and there's this debate of whether or not we're over-medicalizing it, which I won't get into, but the issue is there are huge physiologic consequences of what's happening with menopause, huge. So it's not just the stopping of the menstrual cycle, right? This is all of the consequences of the change in our hormonal milieu. And now that women are living 30 to 40% of their lives in the post-menopause, we're seeing what the consequences are of that much longer. And so again, even though the definition is no menstrual bleeding for 12 months, the impact of that change in hormones lasts the rest of our lives. And so we have to be very thoughtful about what is healthy aging and what is healthy living in all of that time beyond menopause, beyond that last menstrual period.
Right, right. You've both addressed it, but let's go back to the testing for perimenopause, menopause, because there are doctors that will do a test, right? Is there any time that a test works, makes sense during the perimenopause period? And I know your hormones are fluctuating all over the place. If you've hit menopause, is it helpful in any way? Because that is the number one question that I get.
I think when, if there are atypical symptoms or there are other things that are not typically related to menopause, then checking things like your thyroid function testing is warranted, looking for other potential causes before we just say it's that. Usually if you're in the age range, you're having typical symptoms, but checking the labs like your estradiol, your FSH level are not particularly helpful, so no. When it is helpful though is if I have a 25-year-old that's coming in and having those symptoms and not having a period, because now I want to know, is this premature menopause? Is this polycystic ovarian disease? Is this some other endocrine something going on? So I think it's helpful then, but if you're in the average age range and you're having typical symptoms, then we need to manage those symptoms and help you attain a better quality of life. And it's not related to what labs are.
Right, and I just follow up with that to just say, right, like we don't use hormone levels to direct your care. We don't actually need them, right? So we can tell you, women can tell you when they're perimenopausal, their hormones are all over. I don't need a blood test to actually tell me that. Trust women, they know they're perimenopausal. In the post-menopause, we know what their hormone levels are going to be, and we don't use, with the exception of our very early menopausal patients, where we may use blood levels to target appropriate hormone levels in our 30 or a 35-year-old. But in general, we're not using levels to titrate hormones post-menopause, and so they're not very helpful for the average woman, as you heard.
We address symptoms somewhat. There's lists and lists, and every time I think I know the whole list, there's more that seem to be added to it. Let's talk, Dr. Christmas, let's talk more about the symptoms and how women can differ in their menopause experience.
I'll say, and I might get, nobody has any rotten eggs or tomatoes in here, right? Menopause, from the most part, is inextricably tied to the aging process, too. And so when we start adding all of these symptoms down, it's hard to sometimes differentiate. Some of them we do know, absolutely. This is related to hypoestrogenism. But other symptoms, it's like, well, maybe not, or it could be a byproduct of something. So, the most typical things that most of us probably know in the room, the hot flashes, the night sweats. The night sweats can be particularly troublesome if they're disrupting your sleep, right? That can make that brain fog and fatigue and malaise a lot worse too, because certainly if you're not sleeping, those things are going to be worse. So if we think about moving down the body too, aches and pains, joint arthralgias seem to be more prevalent too. Dr. Larkin touched on changes in libido. Sometimes that is related to some of the vaginal changes that can happen. Our vaginas become thinner, drier. The glands in the area make less secretions as well. That potentially could lead to pain with intercourse or bleeding. as well as some urinary symptoms like urgency, frequency, recurrent urinary tract infections. I know this all sounds miserable. Please don't get up and leave. Metabolism changes, as I said, and again, much of we start to lose more muscle tone if we're not doing something about it, right? And that loss of muscle sometimes results in increase in fat, and that fat deposits in one of the worst places that I think it could go, this midsection here. Yep. So from a vanity perspective, I don't want it to go there, but from a health perspective too, that's one of the worst places for it to go, because that increases our risk of all these other things like high blood pressure, diabetes, and the sequelae that can come from those things. Did I miss any?
No. But...
All right.
There's more. Let's talk about some of the different variations in the number of symptoms and in the severity of symptoms as well.
Right, so, not all women are miserable during menopause, right? I like to say it's the rule of thirds. About 30% of women will have pretty mild symptoms and not really be very bothered in terms of hot flashes and night sweats. About 30% will have moderate symptoms. And then there's those of us, and the patients that I see most commonly in practice, right, are the women who are really miserable. And those group of women are having 7, 8, 10 hot flashes a day and at night. I can tell you I'm lucky to be in the category of 15% of women will have lifetime hot flashes. So I had chemotherapy-induced menopause very abruptly at age 49. And what we know is that the majority of women, but not all women, and there's some racial and ethnic diversity in kind of the numbers in terms of frequency, severity, and duration. Most women will start to resolve their hot flashes 1, 2, 3, 4, 5 years after that final menstrual period, but they can last much longer than that, specifically in certain races and ethnicities. But about 15% of women, and sadly I'm in that group, will have lifetime hot flashes that really can be very disturbing. Now, one of the other things I just want to mention is that brain fog that you mentioned that you have, right? So we know that for mood, that there's periods of time in a woman's life when she's more vulnerable, right? So when is that? That's puberty, postpartum, and the perimenopause and menopause transition. And what the common theme is in that period of time is when it's a period of time when there's big hormonal fluxes, right? Things are all over the map. And women in the perimenopause will often talk about their premenstrual mood changes being much worse during that period of time. The brain fog starts around then as well, and I have women coming in who say, I'm afraid I'm developing Alzheimer's, I'm afraid I have dementia. I know there's a whole segment on this coming up later. In general, once women get to the other side, hormone levels now, as I said, are consistent, but they're low. A lot of that brain fog will clear up, and a lot of the mood things will actually get better. The last thing I'm just going to say is the big thing that we see in practice is the sexual dysfunction that happens, the vaginal atrophy, or now called GSM, and we're going to have a section on that too. That often starts much later. So women are very symptomatic. They know they're going through the menopause transition in that 1 to 2 years around their final menstrual period. But often they're not having much sexual dysfunction until 7, 8, 9 years after that final menstrual period, and that's when they're having the symptoms. And they don't always correlate it with menopause, and we know that that's an area where women are really undertreated again, and really we aren't doing a great job taking care of them. And did I miss anything?
No.
All right, let's talk about this. Women, again, as I mentioned, often think they're done with menopause, but we talk about longer health implications to be aware of. Can we go down what the 3 big ones are?
So again, remember I said that menopause is tied to the aging process too. So some of these things are concerning for men as well. Mm-hmm. But certainly the relationship to not having the estrogen anymore sometimes can accelerate these things if we're not, again, doing something about it. So the big 3 areas, I like this slide, cardiovascular health, right? I'm going to jump over the middle one for a second and jump to bones. Risk of bone loss that could potentially lead to osteoporosis. And you think, well, why is that a big deal? Some of the sequelae that can happen with fractures, especially like a hip fracture, has a high morbidity and mortality. But even in just starting to lose height or to have that curvature in the spine, poses not just pain, but quality of life issues too, and being able to function in the way that we want to. And so many of the times, especially when we're talking about the lifestyle modifications that we all should employ, because it's always easy to say, I want the magic jelly bean. And it doesn't exist, right? I wish I could tell you that hormone therapy was the magic jelly bean, and it's not. It's great to help alleviate many of the symptoms, especially that middle section, the vaginal, genital urinary symptoms. It's great for helping with those pesky hot flashes too. But for some of these other things, we actually have to do our part too. And what we choose to put into our bodies to help fuel us to live as long and as independently and autonomously as we want is important. And how we choose to move our bodies and use our brains are important too. So we have to be very intentional about it. And it's a strategic thing for myself even too, of motivating myself to want to exercise every day and do all those things and to fuel my body with those healthy foods. And I think that's the best way to think about how we move into this next phase of life. And I'm hoping that not only talking about these kind of things when you're in the crux of it, but if we start to educate, just like we do about when you're going to get your menstrual cycle, right? There's all that information about it. You learn about it in school. We're getting kits and tool books, but we don't do that for that. Well, actually, we weren't doing it, but we're all here today getting it. But having that same type of preparation for this second stage of life, too.
I just follow up with that to just say this is the most important time for women to get good care. And I say all the time, right, I'm an internist. My patients have gotten old with me, so I have lots of 90-year-old patients that I'm taking care of now. But the gap when women fall through this 40 to 60-year-old range, I can tell you that's the time when if I can adequately assess your risk for developing cardiovascular disease, your risk for osteoporosis, your risk for breast cancer. If I can talk to you about those things and I can implement and help you implement lifestyle strategies to take care of yourself, I'm gonna have the biggest impact on how you age and how long you live. My 80 and 90-year-olds, when I'm tweaking their diabetes meds or I'm tweaking their blood pressure medicines, the impact I'm having on taking care of them in terms of their life expectancy and how they're gonna live is really, really small. So this is the time. Midlife women need to be empowered to make sure that they're really taking stock in their health and getting all of these things taken care of right now, because that's what's going to matter as you get to be 80 and 85 and 90. All of these things play in, and we can't do as much if you already have those issues as a intern.
I'm going to go off the slide for a second and ask you a question. Do you have more women coming in and talking to you or approaching you with more information than you've ever had before? Because I
Absolutely.
Yes? Okay, that's great. That's great.
It speaks shout out to many in the room who are doing a tremendous job on social media. There is noise that has, and clearly all of the stuff going on the Hill and with our current administration is really doing it. But yes, the noise is out there, and more women are coming in talking about all these things.
I'll just say too, Dr. Larkin, something she said made me think about it too. As we're thinking about preparation and living our best lives, it's also understanding what our risk factors are too, right? There are genetic risk factors, and sometimes that can be a scary thought too. If you think, my mom maybe had breast cancer, her mom did, I have a cousin that did too. I'm just going to forget about that because I don't want to think about it. I don't want to will these bad things. Or maybe everybody in my family's had cardiovascular disease. My dad had a massive heart attack or something when he was 45, and so did his dad. But maybe I'm already doing a little bit of things, but really understanding what your risk factors are so we can mitigate against some of those things, which many times we can,
And this goes back to the failure of our health system, right? Which is, again, women aren't getting enough visits with their doctor. When they are seeing their doctor, they don't have a lot of information about the impact of menopause. But then as well, there's 7-minute appointments, or you only get in for your annual visit, and all of this important stuff. And it's my passion now is breast cancer prevention, one of my passions, right? We know that we're only identifying about 10% of women who carry hereditary cancer mutations. We're just doing a terrible job. And part of that, again, is not that doctors don't want to do it. It's A, they're not trained, and B, they don't have time. And it's this fragmentation of our healthcare. So you all need to be advocates for yourself when you're going to see your physician.
Yeah. All right, let's turn to evidence-based treatment options. Now that we've told you all the bad stuff, we're going to try to treat it. Let's talk about some of the options that are available. So we identified the categories of different treatments. We're going to dive a little bit into each one of those, but I'll let you both jump in here. Can you walk through some of the options that we have?
You start.
Okay. Well, I think about it in terms of the pharmacology bucket of things, right? And there's hormonal therapies and non-hormone therapies, and these are the ones that you need a prescription for. And then there are, we'll say, lifestyle modifications and over-the-counter or herbal things or mind-body therapies. So we'll put, some people will call them integrative health modalities or complementary alternative medicine modalities. And then we have our prescription bucket. Many of the prescription options are geared towards specific symptoms. So when we think about hormone therapy, there are systemic dose hormone therapies, meaning that it's hormone that is absorbed or distributed throughout your body. Specifically, most times we think about it in managing moderate to severe hot flashes and night sweats. I don't get to decide how severe or moderate they are. You get to decide that. Moderate to severe genital urinary symptoms. And so most times if those are in isolation, then we don't need to use systemic dose therapy. We can use local estrogen therapy in those areas that aren't systemically absorbed. So they don't often confer maybe the same potential risk that a systemic dose would be. Yesterday we were talking and Dr. Larkin shared a story that she had a patient that was told she couldn't be on her vaginal estrogen anymore because it was going to give her breast cancer. And that's absolutely not true. There's no reason that she couldn't be on that until she didn't care about a dry, itchy vagina anymore all her life, right? The non-hormone, and I guess with the hormone therapy again, for systemic dose, it could be prevention of osteoporosis, as well as we want to manage patients that go into early or premature menopause until they would have at least reached the time of natural menopause. For the other options for managing hot flashes and night sweats in the non-hormone category, there's certain antidepressants that have been shown to have good efficacy and safety. Often these don't work as well as our hormone therapy option does, but for the most case, there's somewhere between maybe a 40 to 70, 40 to 65% chance, or reduction, I should say, in symptoms. But certain antidepressants, one of which is FDA approved with that indication. Another medication is gabapentin or pregabalin. Those are neurologic medications that sometimes are used for chronic pain syndromes, but again, they can help with hot flashes and mitigating hot flashes and night sweats. There's a new medication that was just approved actually a year ago. That's not only a new drug, but a new class of drugs, which is really exciting. In the past, we had always blamed hot flashes and night sweats on the decrease in estrogen. Our ovaries aren't making estrogen anymore, and somehow that is disrupting our body's ability to regulate our temperature. And so now we've got this exciting new research that shows that when that estrogen level drops, our brain sends a signal to release these other neurotransmitters. And with the release of those, they seem to have more of an impact, or maybe equal impact, on our thermoregulatory center. And so this new drug blocks the release of those other neurotransmitters and helps to minimize hot flashes and night sweats. Clonidine is a blood pressure medication. Some people say I don't want to not mention it because you might think I'm not smart if you saw it on when you Google search. It doesn't work so well and has some side effects, so not many people use it for that indication. And then the last one I'll mention is oxybutynin, which is a medicine that is used to treat overactive bladder syndrome. It also has some benefit to minimizing hot flashes and night sweats too. And I'll let you talk about all the other options.
Yeah, so I would tell you that, as Dr. Christmas said, menopausal hormone therapy, we know since 2002, we're not using enough. There's a tremendous need to improve number of women who would benefit from that, right? So in the studies, and I know we're doing a whole segment next, right? Recently, more additional data, again, coming out from the WHI, just really looking at risk versus benefit, particularly in those women close to menopause, 50 to 59, that really the vast majority of women get benefit, not risk. And, again, we should be talking to women and more appropriately educating them, because a lot of women, they've seen a doctor who's told them that hormone therapy is bad, which we'll get to, but then they self-minimize. Like, women will suffer a long time before they actually get to treatment, right? And they have unsubstantiated fears about the options that we have, including hormone therapy. What I see a lot of is, my internal medicine colleagues are using antidepressants first line. And as you heard from Dr. Christmas, right, they don't work as well. Hormones work much better for managing symptoms, and the antidepressants have a lot of side effects for women often who are already having sexual dysfunction because they're transitioning. So they're not as effective. And they certainly help with some of the symptoms, but again, I think for a lot of women, the conversation should be, if you're really symptomatic, hormone therapy may be the better option for you, and we have to kind of take away this overwhelming fear of the breast cancer, which we do have to talk about. But now, the other thing that my internal medicine colleagues are doing is telling women that it's natural and they just should go out and get supplements. So just last year, the Menopause Society did a really comprehensive review of the non-hormonal options that Dr. Christmas just talked about, and included in there were a lot of the supplements to review kind of what the data was. And my bias really is, in general, I'm not a supplement pusher in my practice. I say pusher, I don't mean that to sound so negative, right? I refer a lot to my integrative medicine and my functional medicine colleagues when patients have a desire to try to use supplements, because that's not my area of expertise. But in looking at the data that the Menopause Society did, there's just not a lot of randomized trials for these things, right? The data is not great. So the end conclusion of the Menopause Society was they really couldn't recommend a lot of these supplements. Where I have a big concern, and I talk about this a lot, is that their formulations are not regulated very well. So there are a lot of things, when you look at bottles, it'll say proprietary blend. These are mixtures of things. You don't really know what's in them. The dosing isn't regulated batch to batch. There can be variability. The FDA doesn't regulate these things the same way. In the vast majority of women who are young and healthy, I don't think these are harmful most of the time, right? I say, yeah, you're spending $800 a month to make your urine expensive, but not doing very much. But where I have an issue is in women who have other medical problems, particularly my breast cancer survivors who are on other medications. These things have just not been studied with drug-drug interactions, and so I'm really cautious in those patients. And my take-home is, if you're a healthy 50-year-old and you want to try these supplements, I don't think they work. Believe me, I've tried every single one on the market. I don't think they work well, and the data does not support that there's enough study of them. But again, in breast cancer survivors, people with other issues, I'm much more reluctant to recommend them.
I know we're going to talk more about symptoms within the other panels, but I want to circle back to something that that you brushed on and we talked about. We've talked about everybody comes to this, individually. Everybody has different symptoms based on age, also based on race and ethnicity. And I want to address that because there was a SWAN study too that I think that we should talk about and explain, and where it brings us today and what we know and what we don't know.
So SWAN is the study of women's health across the nation, and Chicago happens to be one of the intake sites, but it was the first of its kind longitudinal study looking at women as we progress through this aging process. I think initially the cross-section was 1997, so it's been going on for a long time. We're still using this data. There's still patients that are still enrolled in the study are being evaluated, but there were over 3,300 women that have been followed. We took women from 7 different geographic areas through the United States and had different ethnic groups that were followed. So there's a white cohort, there's an African American cohort, Hispanic, Chinese, Japanese, and looked at really every aspect of menopause. These women were very courageous for volunteering to do this, but they had lab work done. They fill out more questionnaires than I could even think. So there's a lot of robust data, ton of information that's come from SWAN, that's still coming from SWAN. But one of the big things that they found was that there's some variation in how women experience menopausal symptoms, especially those vasomotor symptoms, the hot flashes and night sweats. And Black women like myself, we tend to have them for a longer duration of time. Our symptoms tend to be more frequent, more severe, and more bothersome too, for whatever reason. tend to be someone, when I get a hot flash, not only does it make my heart race too, but I start to feel really dizzy. To the point where I might like pass out. And sometimes in the operating room, I like it to be ice cold. And sometimes for the patient's benefit, it can't be ice cold. And my anesthesia colleagues are like, dude, we gotta crank the temperature up, I'm sorry. As soon as they start cranking the temperature up, my temperature starts cranking up and I start to get those feelings that are bothersome. Plus I'm drenched when I take everything off. And if I have a meeting later, I don't wanna go back in with an afro. So what I have them do is tape ice to the back of my neck and my lower back, ice packs. There's literally tape, they tape around my neck. And my chairman came in, who's this very serious German man, and he's like, what are they doing to you? It's like, dude, mind your business. I'm having a hot flash. What are you here for? No one called you. So, some newer data, too, that's showing that Native American women also have more severe, longer hot flashes and night sweats, too. Lots of other things have come from SWAN, but that's one of the big things is variation and degree of symptom bother. Now, that still does not mean that every Black woman has hot flashes or night sweats. So that's not the takeaway for us here, too, or even from my colleagues. So I have plenty of patients that are like, yeah, never had those, Dr. Christmas. That sucks for you, Okay.
One of the things I would just follow up with about the hot flashes is, the other thing I hear from my internal medicine colleagues who are taking care of women and telling them just to take supplements and that it'll pass, right, is that this is just a lifestyle thing, right, which is like it's just a hot flash. Well, I want to tell you, my sweet husband would tell you, he has seen me suffer through these and would say, oh my God, if men ever went through this, like we would have a cure for this already. Like this is like no idea. And when my hot flashes are bad, I disrupt my husband's sleep, right? I'm having drenching sweats at night. But the point I want to make is they're more than lifestyle, right? Thanks to a lot of good research that's been done by one of our colleagues, Rebecca Thurston. Hot flashes suggest that there's something different about women that are having severe hot flashes in terms of, we call it autonomic dysregulation, right? Their vasculature is not responding exactly the same way. And we know now that there's differences in cardiovascular risk with women who have more severe hot flashes. So again, we're learning a lot of this data and we're starting to understand it, but the important takeaway is we should not minimize these symptoms for women, right? We need to empower women to say, look, these are not only real, it is more than lifestyle. I have executives who come to see me. I had one recently who said, I sit in a boardroom and I suddenly sweat, it's uncontrollable, and my hair gets wet, and I'm in a boardroom with all of these men, and they're looking at me like there's something crazy, you have to do something for me, right? So it's more than lifestyle, because again, it is another marker that we need to think about and be very careful with women about what is future risk, what is cardiovascular risk, what is dementia risk, we really need to assess this in the context of this subgroup of women who are really having these severe vasomotor symptoms and really stop these other doctors. We need to educate them. My whole thing now is we need to educate doctors about this information because they need to stop messaging the wrong thing to women because this is really an important time.
Which is where I think that women have to become their own advocate, and I hate to say that because it puts the onus on them, but at the end of the day, to know what's going on, to have the tips, the guidelines, the symptoms, understand what's happening, so you can go in there armed and not accept those kind of answers. Okay, so guess what? It's time for some Q&A. You guys ready? Yeah? Okay. I think we're just going to do it by raise of hand, and Donna's going to bring a mic around. Just remember, please refrain from personal medical questions.
And also, if you can try to keep it to the topic, just sort of perimenopause, menopause, and beyond, that would be great. We're going to be doing a panel on hormone therapy where questions will get answered. We're going to do a panel on GSM, the genitourinary symptoms, and we're going to do a panel on mood. So if there's more specific questions to those, you can keep them. Actually, the hormone therapy, we're not actually going to have a Q&A, I don't think. But we will have a follow-up Q&A. So I'm going to get to who raised their hand. Someone here? And if you could also just keep it kind of short, the question.
Hello, I'm Dr. App and a recent or somewhat recent menopause certified provider, and I appreciate all of the work that you all are doing to support menopause treatment and education. Fighting the good fight. What about those patients that come in with all the pellets and all the what I practice evidence-based medicine, and I know we're not supposed to do them, and I'm not doing them, but how do you convince them not to, as well as how to convince them that they don't need their labs checked?
I'm happy to start and you fill in. So this has become a big segment of my practice, right? Which is women who've been doing pellets for a while now come in and they recognize, they're spending a lot of money and they're starting to see stuff on social media or whatever, or they may not be feeling so well with pellets, they're starting to have their side effects and they want to get off of pellets, right? And I'm really not a supporter of pellets. I have seen crazy physiologic or crazy levels in women with pellets. So the people who are doing the pellets, the vast majority of them are checking levels at the nadir, right before the patient gets the next pellet, as a way to reassure the woman that they're not getting super physiologic levels. I've had crazy levels that when I draw, because I try to convince them that they are having super physiologic levels, particularly of testosterone, because they're having the effects of testosterone, which is why they're in my office now. And I can examine a patient and see who's been on pellets for a long time with this super physiologic dosing. I also happen to have a transgender stepson who's on testosterone who wants those androgenic effects. And so you have to talk, I talk to patients and I say, like, these are the same hormones, right? And, you know, the dosing really matters. And we need to really make sure that women understand that compounded and these dosing of pellets, it's not the same as FDA-approved options. We have, if the term bioidentical is not the same as compounded pellets, we have to go back and really educate that bioidentical forms of hormones, there are FDA-approved options, and we can do them in a physiologic dosing range that's really appropriate. What I like to say, though, is that the reason, in my opinion, that pellets are such a rage still is because the first time a woman gets a pellet, particularly with the testosterone, they get very high dose testosterone and they are euphoric. Their hot flashes stop, their libido is tremendous, they lose a little bit of fat and gain a little bit of muscle mass, they notice body changes very quickly. That first pellet is a game changer for a lot of women, and they run around and tell 1,000 of their friends that they should get a pellet because they feel so well. But if you talk to women, and what we have started to learn and understand is that, so the brain in a woman who's never seen that high dose testosterone before, that's part of the euphoria, right? And they tachyphylax to that over time, meaning that the brain suddenly starts to get used to that high dose of testosterone, and they don't have, with subsequent pellets, women do not feel as well as they used to. So they keep getting the dose increased, or the frequency changes, or they're going back. I've seen crazy things in my community of what kind of adjustments are made to women when they're doing this, but they generally don't feel as well. They don't have that euphoria anymore. And actually what starts to happen is they actually start to gain weight, and then they start to have some of the androgenic effects. And so, I mean, in patients who are coming in and haven't been on pellets, I can really go through all of that and say, I can help you without using pellets. For the patients that come to see me who've been on pellets for a long time, they already know all these things, and they're anxious to get off. And I will tell you, it's a transition. Women, when they go off the pellets, do not feel well for several months. And it really is educating them that they should expect this. And I really work with them in terms of what we do to manage them for the 3 to 6 months, again, while the brain kind of reacclimates to kind of normal physiologic hormone levels. So.
Thank you. So,
I was going to say real quick, I have lots of pellet stories too that are not particularly good, but I have a good friend who had pulmonary embolism, and that's normally a contraindication for hormone therapy. And she somebody gave her pellets, and she was like, "Oh my gosh, I feel great." And and now and put it on like her social media stuff too, that like everybody should do this. And I thought, not only should everybody not do this, but you shouldn't do this. You had a pulmonary embolism. Please tell me you're still on anticoagulation right now, which she wasn't. And it became a big thing. I was like, you need to go in and see your internist now. Let them know what you did, because once you get a pellet, we can't take it back. It's in your system. Sorry, I will let you take the next question.
Can the panelists, when we ask questions, just repeat the question? Because
I'm
we're actually
so
live
sorry.
streaming. Oh, no, we failed to tell you. We're actually live streaming, so for our audience not in the room with us. So we know that everyone has a ton of questions.
Sorry.
And just to know that we do also have a hormone therapy panel, and also just in terms of testosterone pellets, just can you explain that just a tiny bit, because I think we didn't get to that. Like what are they?
Oh. Well, so no, these are, women who are having menopausal symptoms who, again, largely, I feel bad for women. I know why they end up in these hormone centers. I know why they get these pellets is because we failed them, frankly. There just aren't enough of us that are knowledgeable, and women are falling through the cracks, right? So they find places to go. And, depending on the setting, women are really, unfortunately, misinformed about what they're about to have inserted into their body, right? It's told that it's bioidentical and safer. And again, this patient who had a prior pulmonary embolus, what I see all the time is that they don't often get a physical exam, they don't have a good medical history taken, and when they have complications from their pellets, bleeding, for example, the hormone center isn't managing that at all. They get sent to me. I can't tell you the number of times I get a patient who comes in who's been getting these pellets who now is bleeding, and the hormone center said, oh, we don't manage that. Like, I'm not sure how you can be prescribing medications and putting pellets in if you're not managing the complications of that. I have a real issue. But long answer to just say, testosterone pellets are a way women are symptomatic. They are noticing a decrease in libido. They're having hot flashes. And so these pellets can be a mixture of estrogen and testosterone, or a lot of times just testosterone in younger perimenopausal women. They're putting them in, which gives very high physiologic or supraphysiologic doses of pellets. And these pellets last for typically 12 weeks. Women are getting them about every 3 months. It's a procedure to put them in their buttock, and it's out of pocket and cash, not covered by insurance. And again.
Okay.
Katie, are you?
How about right here? There you go. Okay.
First of all, thank you for being here, and for the organizers and everybody here. What an incredible resource you're providing for women today. So thank you. I was really surprised to hear you both say that blood tests are kind of inconsequential for deciding hormone treatment. And so I guess my question is, what's your general advice? I live in Indianapolis, and there are some providers starting to see women in this arena, but
Yes.
Good luck getting into them because there are so few. And so do you have general advice, particularly if you live in an area where there aren't enough of these providers, or language for talking with the providers that you do have to start this conversation? And what are you asking for? What should you ask for?
So I think the first part of it is really just to be organized when you're going in to see the provider, because at best, if you're a new patient, they might have 30 minutes to see you, right? If you're a return patient, it's probably 15 minutes. And so be kind to your providers when they run late, okay? Because that's
We were
really
talking about yesterday.
Yeah, really, because that's, and it's not because we are greedy and want to make more money. My salary's the same no matter, I run late all the time, but it's because I wasn't a good steward of my, of my business, and I work for a major university that tells me how many people I have to see to be productive. So that's the first part. So when you go in, you actually really need to know what you want to talk about. You need to know what your symptoms are. You can write them all down so that you can clearly and succinctly state them. Annual visit is not a problem visit. So when you make an annual appointment to see your provider, that's really, I'm doing a pap smear for you, I'm doing your breast exam, maybe ordering your mammogram, your colonoscopy, whatever, bone density scan, you don't really have any issues. As soon as you start talking about problems, that's a problem visit. Now, some of us are really nice because we know it was hard to get in, so we'll answer those questions, but it'll be fast. So the best thing you do is when you're scheduling the appointment, saying what you're coming in for, when you get there, having all the things written down, knowing what you've already tried that didn't work, right? Being very well aware of what your past medical history is. You can't assume, they should know it because it's all in there. it probably is all in there, but sometimes we don't have time to go through every provider's note that you've seen, right? And if there's been a change from the previous year, either in yourself or in your family, that's important. So in those first few minutes of that encounter, you need to be able to be very clear, this is what's going on. I'm having hot flashes and night sweats that are happening multiple times a day throughout the night. I'm not sleeping well. I can't function this way. I need to know what my options are. And I've thought about hormone therapy or whatever, right? And I think that's how you lead the conversation to help direct it. Because oftentimes when you've come in clearly like that, even if the person says, you know what, and I'm not bashing because I think there are many wonderful family practice doctors, but maybe I'm family practice, I don't really do that. I'm going to send you to one of my colleagues that does specialize in that. They're more willing to help get you to the place that you need to be, even if it's not their area of expertise. In terms of the hormone levels, is that, if you think about it this way, I tell people 50% of us, if we're lucky to live long enough, are going to go through menopause. And everybody that goes through menopause is going to have zero estrogen, progesterone, whatever, right? But not everybody has symptoms, right? So even when I'm managing your symptoms, I'm just trying to help improve them, right? And it doesn't matter what that level is, because I'm not treating to a certain level. And I think when we start to get into this concept of wanting numbers of our head is that, we're trying to figure out, well, what do I need to do? Where do I need to be perfect, where I don't have any aging symptoms happening? And that's, again, like I said, I don't have the magic antidote to aging. None of us do.
But I'll follow up on a couple specific things. So in my younger generation now, right? I'm old, been doing this a long time. Data, my patients want data. I mean, it's amazing what's out there now. So I have my non-diabetic patients doing continuous glucose monitors. Everybody's doing their body composition and tracking that, and tracking calories, and it's fascinating. And so that I understand where this desire to have more information about where you are in the menopause transition and these blood tests, and now there's over-the-counter testing that you can get too. So the truth is, I don't mind if you do that test and you spend your money on that. Like, if you go pick that up at Walgreens and you want to do that, that's okay. What I would tell you though is I don't need that to decide how to take care of you, right? You can tell me, I trust you that you're having symptoms that are perimenopausal, and I can define that. And my management of you is not going to change based on what information you've just brought me into the office. The second thing I would just say is, again, be empowered. So I think there's tremendous resources out there. Let's Talk Menopause, the Menopause Society, lots of our social media, podcasters, physician influencers. There's lots of information out there now that's good information. And if you use those resources and have a sense of what you're thinking, again, it's hard to sort out. Patients tell me all the time they've been watching this stuff. They still can't really understand if they're a candidate for hormones or they should take hormones. But having a framework of going in helps when you can, again, be very focused with what you need with your physician. And then finally, if you get the answer from the physician, which too many women are still getting, which is, it's normal. Oh, I had a patient come in who saw her internist who came to me and said, he told me that their entire practice was a hormone-free practice. What does that mean? Like it's a statin-free practice, it's a thyroid-free practice. Like what does that mean? Like that's the level of lack of information that's out there. So if you have that experience, I would just encourage you, again, there's resources for finding a provider from the Menopause Society. There's lots of great telemedicine programs that are happening now if resources are bad in your community that you can try. So there's lots going on, but you have to advocate for yourself.
And I would also say, just on that note, the QR code up there on your screen, you can check out the Let's Talk Menopause Guide resources, including tips for finding a menopause practitioner and getting care, and those are really great guides. So the QR code is going to be up throughout the day. Okay, we have a few minutes left of this panel. I have one up here at the front too, Donna. Can I? Yeah, because she was waiting. Can we?
I don't know. There you go.
Thank you for all of your information. I guess what I'm about to say might be, I don't mean it to be harsh, but we focused an awful lot on, sorry, I don't know how to use a microphone, on hot flashes. That was not my experience. I have an autoimmune disorder. I have sexual dysfunction. No doctor talks to me about that. Nobody talked to me about all the other types of side effects. And I guess it's frustrating because we're still focusing on this one symptom that not everybody has. It took me a long time to find a doctor. She happens to be here today, Dr. Rahman, who knew how to help me. Sorry, I'm emotional. It was a lot. It was a long journey. Anyway, I'm done.
And
It's not really a question.
I apologize that you feel that way. I think one of the reasons is because we have a whole segment at the end about that. And I would just say, I mean, I hope that we gave you the impression that there's a spectrum of symptoms. And absolutely, I mean, again, I'm sorry that you've had that experience. And I'm sure you worked very hard to advocate for yourself to get where you are. I mean, I can tell you that all of us in practice, we do talk a lot about sexual function with that. And I think we didn't focus on that right now because of the nature of this portion of the panel. But
We're gonna have a whole panel at the end for that
I
30
hear
minute
you.
hour.
And again, I mean, this is about trust women. Women, if you talk to women, I mean, I'm the internist. I take the history. I mean, I tell the medical students, right? Like, you can get everything from a history if you actually spend the time actually talking to the patient. They'll tell you what you need to know. And like, that's, again, we need to have time to listen and to hear you, and you need to advocate for yourself, and which you did, obviously. But it is a huge mess, and I'm sorry you had that experience.
Okay, Donna.
First, I do want to thank you guys for being here, because it's very nice to know, like, struggling, that there are women like you that advocate for women struggling like us. And I really appreciate that more than I can say. I did want to know, one of the biggest markers of perimenopause for me was panic attacks. And I feel like that's not often discussed. And I had to go through hurdles to find out where mine were coming from. And I was kind of wondering if those also come from the same type of hormone imbalance that causes things like heart palpitations.
So I can tell you I see that in practice all the time, right? Women who have never had mood disturbance before, who, I mean, I have a patient who I have, again, I'm old, I've been taking care of patients for a long time. You know, she's been my patient for 20 years, never had any issues like this, who literally called me from the side of the road, pulled over with a panic attack saying, I don't know what's happening to me. I just called my husband to come pick me up. I can't drive. Like, I'm a crazy person. Like, there's something wrong. And it really was completely hormonally driven. And I know we're going to do a whole section coming up. But again, it's that period of time when it is a window of vulnerability where the hormone changes that you're having, it's not the absolute level. This goes back to, again, why we don't need to measure actual levels. Because again, I don't need a level to tell you what's happening to you. You're telling me what's happening to you. And it is related to these huge swings that you're having. Many times in the perimenopause, hormone levels are actually higher than they were during the peak reproductive years of the 20s and 30s, right? And then they drop very abruptly, which is why migraines are often much worse in the perimenopause. But the mood disturbance you're describing is 100% related, and we'll hear more about that. It's really a common thing that I see. And again, it's the common thing where my colleagues, because they don't know the data and they don't do this and they don't think about it through a lens of, my gosh, my patient actually is perimenopausal and having these hormonal things, maybe I need to think about that as contributing to it, as opposed to just saying, you know, you're under too much stress and you need to exercise more and here's an antidepressant. But your experience I see in practice commonly.
And those things do help too, though. But when we say
Yes,
many,
yes.
40% of women will experience mood changes or even anxiety, as you described. And if you have a history of having depression or anxiety, even if it was postpartum depression, and let's say you've been stable for many, many years, you're at a higher risk of recurrence or around that perimenopausal time frame. And it's amazing to me sometimes that even when I just explain that, people will take a sigh of relief and say, okay. And then many of them don't, when I start to delve into what we can do to help and give treatment, they're like, no, I actually don't think I need anything. I just needed to know that this was normal, that there wasn't something wrong, so.
And I will just follow up, just to say that in the perimenopause, one of the things that often works very well and is helpful is continuous oral contraceptives, right? So what the continuous oral contraceptives do is quiet ovarian production of hormones, which is all over the map, right? And then we're giving you even doses of hormones back. And it can be very helpful for the mood as well. So there's lots of different treatment approaches, but again, back to Dr. Christmas's point, I agree. I mean, I think sometimes just women understanding that this is real, there's real physiology behind this, is really empowering to say, I am not crazy, and this is like a time of life, this is bumpy, this is hard. Like, it gets better on the other side for many women, but like, it's real what you're having, and we should address it.
Well, I know we didn't get all the questions answered. We are going to have an opportunity to ask them during the other panels, so please make note of that. And also, there's going to be a menopause talk in June focused on answering just questions that did not get answered today. So thank you both so much.
All right.
Thank you.
Thank you.